CCP Presentation by Jasmine Whaley. Patient is a 22-year-old adult Hispanic female, full-time WLAC dental assistant student, no medical precautions. Patient is classified as ASA1 due to no current or prior history of systemic disease, no known allergies. Vital signs were within normal limits, showing no elevations or abnormalities. Patient is considered a normal, healthy patient. Patient has had no extensive dental restorative treatment as a child or teenager, has only received sporadic oral health care in the past 10 years. Hygiene visits and dental exams were not routinely scheduled nor attended. Patient does not have a general dentist or dental office right now other than her orthodontist. Orthodontic treatment began May 2017. Patient elected to begin orthodontic treatment to straighten her teeth and to close diastemas. Patient stated that she uses a manual soft bristle toothbrush, fluoridated toothpaste, and flosses every day or every other day. She did mention that she finds flossing frustrating maneuvering around braces. She wishes that there was an easier way. The patient's chief complaint was, I have soreness on the inside of my cheek on the upper left because of irritation from the wire of my braces. Upon inspection, I did find what the patient described as very tender and painful, a 3 by 2 millimeter traumatic ulcerative lesion on the left buccal tissue, 0.5 millimeters inferior to Stenson's duct, as a result of direct trauma from protruding orthodontic wire in that area. I advised the patient to inform her orthodontist of the occurrence, but she stated she had done so already, and the remedy was to use ortho wax to reduce the instances of tissue trauma or bending of the wire, but both options provided no relief. During the TMJ assessment, although the patient denied pain or any other indication of TMD, I did notice slight popping of the TMJ on the patient's left side. Another finding was a white papule on the superior portion of the left tonsil that I used a cotton tip applicator to gently wipe the finding, which proved not wipeable and therefore negative for candidiasis. I asked the patient additional questions about the findings, such as if she was feeling a sore throat, allergies, or could recall any recent throat irritations. She denied all three. The patient presented with bilateral salivary flow from the Stenson's duct. No parotid gland obstruction or enlargements were felt upon extraoral and intraoral palpation. Occlusal relationship was class 1 all around on the right and left canine molars. The facial profile is mesiognathic, and the maximum opening 44 millimeters, overbite 1 millimeter, and overjet was actually 1 millimeter despite what it says on the slide. Presented with moderate supragingival calculus deposits on the lower anterior lingual aspect, the buccal surfaces of her molars along the gingival margin, bilateral operculum on numbers 17 and 32. On numbers 5 and 13, the teeth are almost completely covered with the bracket, and the gingival tissue was very inflamed there. Not only was the gingiva constantly irritated, adequate plaque removal was almost insurmountable. Finally, you see the protrusion of the orthodontic wire, which was generalized.
Maxillary free gingiva is generalized reddish pink. Attached gingiva is generalized pink, firm consistency. Keratinized free gingiva, stippled attached, generalized rolled borders, and localized edematous rolled borders on numbers 5 and 11. The mandibular region was generalized pink. Generalized edematous free gingiva was spongy, attached with localized fibrotic consistency on number 18, shiny texture, and generalized rolled borders, and blunted
Intradental papilla. I've included both pre- and post-treatment radiographic images for better visual representation of the patient's teeth captured radiographically. The panoramic radiograph was provided by the patient from her orthodontist during orthodontic treatment, which is all I had to reference until post-dental hygiene treatment, which happened to also be post-orthodontic treatment. The images show a generalized 1:2 crown-to-root ratio, pulp cavity within normal limits, vertical radiographic bone loss on numbers 19 mesial, and slight VBL on number 30 mesial. Vertical radiographic bone loss seen on the mesial of number 19 could be due to the force being exerted on that tooth, as it is the last tooth on the left side in orthodontic treatment, and the intentional movement of the tooth in the mesial direction, because the pocket depth there was only 3 millimeters. The alveolar crest level was generally within normal limits otherwise. Thickening of the lamina dura periapically on numbers 3 and 13 could signify these two teeth have been subjected to heavy occlusion with opposing teeth. There was a slight widening of the PDL on numbers 18 and 19 mesial distal and 30 and 31 mesial distal surface. The contributing factor is most likely due to the movement of the teeth via orthodontic treatment and further facilitated by plaque retention due to the fixed orthodontic appliance. No defective restorations were observed clinically nor radiographically. I am aware that orthodontic forces on the teeth can result in root resorption. The anterior PAs appear to show generalized shorter than normal roots, but I believe the appearance of the shortened roots can be attributed to a radiographic technique error. For the pretreatment periodontal assessment, the patient presented with generalized 2 to 3 millimeter probing depths, localized 4 millimeter on number 31 mesiolingual, 32 mesiofacial, 13 distal buccal, 1 millimeter recession on numbers 31 buccal, 26 lingual, 1 millimeter pseudopocket on numbers 5, 14, 22 through 26. Count was generalized 1 to 2, localized 4 in the lower right and upper left posterior region. Marginal bleeding index will be discussed on the next slide. No mobility detected and also no MGI. Westlake calc code was light 2, and the patient's AAP is generalized plaque biofilm induced gingivitis, localized stage 1 periodontitis on numbers 19 and 30, modified by plaque retention facilitated by orthodontic treatment. For the baseline plaque and bleeding indices, patient presented with a 45% plaque index and 13% bleeding index. Patient's OH was poor. Patient was not aware of proper flossing and or brushing modifications most suitable for orthodontic treatment.
The patient's daily dialogues revealed interesting findings. The patient only hit 63% of all daily recommended targets for micro and macronutrients, caloric and water intake included. Patient underconsumed water every day. The only area that was consistently surpassed in regards to daily target was vitamin A. Due to hyposalivation and underconsumption of water, it is recommended for the patient to significantly increase water intake. I advise that she follow the 8x8 rule, 8 glasses of 8 ounces of water per day at minimum. I asked the patient if she was sure that she reported everything she consumed each day, and she assured me that the logs were correct. I believe the patient did not eat a lot due to discomfort sometimes caused by tightening of the orthodontic wire or buccal mucosal irritation from protruding wire or bracket abrasion. Nutritional counseling was recommended. So the patient ranked at a high caries risk, and the patient is high risk for caries. The most contributing factor is poor oral hygiene, hyposalivation, and the presence of orthodontic appliance.
The first technique that needed adjusting was the patient's toothbrushing method. The first OHI given was a breakdown of the Charter's toothbrushing method. I demonstrated the Charter's method using the tail shall do technique. I explained and demonstrated the Charter's toothbrushing method, provided and demonstrated proper flossing technique to maneuver around orthodontic brackets and wires using superfloss, floss setters, and proxy brush. I suggested that the patient consider purchasing a water pick or using the proxy brush to meticulously clean the distals of numbers 17 and 32 where operculum is present to avoid increased pocket depth and avoid pericoronitis. I also suggested the patient use xylitol gum or sugar-free gum to stimulate salivary production and use high-concentrated fluoridated toothpaste such as Prevident 5000 Plus. For the high-concentrated fluoridated toothpaste and antibacterial rinse, I advise that the patient seek a DDS to be examined and then given the prescription for the 1.1% sodium fluoride for daily use, which is recommended since the patient is at a high risk for caries and has hyposalivation without any known causes. Based on the patient's periodontal assessment during appointment 1, full mouth hand scaling was performed during appointment 2. Appointment 3, the reevaluation appointment, did not take place until almost 2 months after initial treatment due to scheduling conflicts, clinic shutdowns, and other unforeseen circumstances. During the reevaluation appointment, retreatment of lower anterior linguals was performed as well as an occlusal sealant placed on number 21. To monitor the progression of localized bone loss, the recommendation for this patient with a poor prognosis is to come back on a 4-month recall interval for perio maintenance. All appointments happened in the order and according to the original treatment plan. However, the 15-week time span between appointments 2 and 3 was unplanned and not ideal for completion of treatment. 15 weeks after treatment, patient presented to reevaluation appointment with no braces. Patient compliance was fair. There was an overall 2% reduction for both indices, plaque and marginal bleeding. Patient was able to demonstrate her new home care routine implementing the tools and techniques discussed previously. Patient has not increased her intake of water. She also decreased her snacking frequency of fermentable carbohydrates and carbonated beverages. She increased her consumption of tea, mostly unsweetened. Patient has not seen a DDS for evaluation of numbers 18 and 31 for curious lesions. She says that she plans to speak with her orthodontist first for the DDS recommendation. Although patient was given and recommended to use Biotene oral rinse gel and spray to help with dry mouth, she has not incorporated the use of those products because she says that she is not always aware that she has a low salivary flow. The patient's post-treatment gingival condition improved significantly. Generalized reduced inflammation, reduced gingival and mucosal irritation, and no visible supragingival calculus. However, Treatment goals were partially met. There was a reduction in inflammation, bleeding, supra and subgingival calculus accumulation, but more 4 millimeter probing depths were observed, which means that goal saw an increase instead of reduction. I believe there was an increase in probing depths within the posterior region because of the failure to adequately adjust toothbrushing technique once orthodontic appliance was removed. Patient stated that she had been more consistent with flossing, but based on the post-treatment plaque index, there still seems to be an inadequacy with plaque removal interproximally. There were no new active caries lesions, which was an extremely positive finding, being that the patient is considered high risk for caries. This could have been due to an increase in fluoride use as recommended during initial OHI. Gingival enlargement facilitated by orthodontic appliance. The moderate gingival inflammation, I believe, was more than just plaque-induced. I also hypothesized that the orthodontic appliance contributed to the gingival irritation and consequently caused the moderate inflammation. The research that I found backs my hypothesis. Per the research, the proposed treatment was a gingivectomy procedure to eliminate pseudopockets. However, with my patient, non-surgical methods were used and proven effective. Removal of plaque and calculus deposits via the scaling and replaning procedure, coupled with improved oral hygiene and removal of the irritant, the orthodontic appliance, the gingival condition improved and also resulted in a pocket depth decreased by 2 millimeters at the site shown, tooth number 13. I am interested in finding out whether the removal of the fixed orthodontic appliance will have any effect on the salivary flow. With the removal of both the orthodontia and the hyposalivation, this patient could achieve oral microbial balance, which will then classify her within the low to moderate caries risk category. This patient does show willingness to comply. I do plan to keep in contact with this person and continue to encourage oral health maintenance and continued care. Thank you. Woo!